So today we have Carolyn Lara, the care coordinator for CMAR since 2012, a lifestyle coach since 2013, and a community health worker since 2014. So everyone please welcome Carolyn Lara.
Hi, good afternoon. How's everyone doing today?
Good.
Enjoying your lunch? Yeah. Great, smells delicious. So, like you mentioned, I am Caroline. I've been working for CMAR for quite some time, and I've taken a couple of different roles with the organization. But I'm mainly going to discuss today the barriers to care when managing chronic conditions in the primary setting. I would like to start by thanking the University of Washington for giving me the opportunity to share some of my experiences. My experiences while working and providing care to low-income and homeless patients. As I mentioned, I am the chronic care coordinator for this community health center that serves mainly the Western Washington area, CMAR Community Health Center. The care coordination role is mainly designed to assist patients with chronic conditions such as uncontrolled diabetes, hypertension, asthma, anxiety, by providing resources and guidance with purposes of obtaining better health outcomes. The main topics that I will be discussing in this presentation will be covering the barriers to care when managing the chronic conditions. A lot of the times the ideal method is to provide certain treatment options or certain approaches to treat their diagnoses. However, the barriers that might come with that with every patient might vary. So the foundation for providing care for chronic illness despite the barriers. So we initiate the approach by providing one-on-one care. The provider would meet with the patient. They would discuss the diagnoses, where the patient is currently at, the treatment plan, and off the patient was with a lot of questions, having a list of new prescriptions, but there was a lot of questions regarding what the next steps are. That's where the patient-centered medical home comes into place. The purpose of this is to approach the patient's care in a team-based model. So now it's not just the provider providing the care to the patient, but it's the patient receiving the care as a whole team. The main reason of adapting this approach in the primary care is due to the increased number of patients from suffering major chronic conditions that at the moment are not controlled. Conditions which face many obstacles in managing, and these obstacles in consideration to be obtaining with the appropriate medical care that often does not meet their needs for effective clinical management. So a lot of the times these patients are coming to the clinic, the provider has a specific plan, but the patient didn't quite understand, has a few questions about the medications, and since the appointment was only a 15-minute appointment, he or she does not have the time to address this with the provider. The primary reason of this might be the mismatch between the needs and, like I mentioned, the care delivery that we currently have. It's mainly designed to target the acute illnesses where the provider has limited amount of time to meet with the patient, come up with the diagnoses, treat, and move on to the next patient. So that's where a lot of the patient-centered medical homes have adapted the chronic care model. So the chronic care model, where we initiate by taking into consideration the community resources and policies, and that's where the community health workers come into play. Community health workers are the patient or the people assigned to connect the patients and the population of the community to the resources that might be needed. So the first approach would be the community approach, finding those patients who is in need of the help, And once that has been determined, we can move forward to the healthcare system. Based on the healthcare system, we have to organize it in a manner that we can provide a self-management support for these patients, deliver a system, and assist with support provision and clinical information in the clinical information setting. So the big two components about making sure that the chronic care model is effective is by coordinating with the staff that are available at the different locations. So in this case, coordination of care is a key role to ensure that not just only the staff is involved, but also the patients are aware of what staff will be involved in their care. And the overall goal is to improve the patient's healthcare outcomes. So I'm going to start by describing a little bit of each of the different roles in the patient-centered medical home. We can initiate with the care coordination, whose primary role is to discuss the patient's resources available, possible barriers that the patient might be facing, the overall coordination of the other departments or services that might be involved in the patient's care in order to determine how to approach these. So a lot of the times we see patients that were recently discharged from hospitals or rehab facility. They have a certain amount of prescriptions that have not been filled, and they're now back at our office asking, where do I go next? So that's where the care coordination comes into play, ensuring that we are in communication with our staff on site and any other resources that might be involved in the patient's care. The next role here is health education. And health education is the resource that provides an overall education about the chronic condition, which includes the visual explanation of the condition by reviewing the causes, signs, and symptoms, and the different types of medication, that various treatment options, and overall management. Explanation of what the condition is. So what I like to tell patients about health education, it's more like meeting with a guru that can explain a little more of the condition. This is like an encyclopedia. If you have questions, concerns, the health educator is the resource to go. They still have the mentality that questions should be addressed to the provider, but when they're not addressed because of the limited time that the provider had to spend with the patient, they feel like they weren't heard. So ensuring that the patients are aware of the services of health education to get those needs met, to get those questions answered, is a key part of the patient-centered medical home. The other part is nutrition education. The nutrition education provides an overall education about the relationship between the food and the chronic condition that the patient might have. Ways of overcoming challenges presented with healthy eating, such as time, budget, and motivation. So a lot of the times patients are reluctant into actually being referred to our nutrition department. They mention that they are aware of what to eat and what not to eat, but even though they're still not with a controlled condition. So the approach taken here is, like I mentioned, to go over the barriers that a patient might be having. You know, we understand that schedules may vary. We understand that the patient's living situation may vary. So not all of them have the option to cook the proper meals or even have the budget to afford the meals that are recommending. So working around those barriers and creating a plan that works specifically for them is what the nutrition services are designed to. So another big component about the patient-centered medical home is a care management team, which is composed of a registered nurse, a social worker, and a counselor. This team is designed to those patients with a combination of chronic conditions along with social factors that place them at a higher risk of developing further complications. It's designed to assist with the social and medical factors that might be interfering with their care, such as lack of reliable transportation, unstable housing, limited to no income, connecting the patients to the correct services and resources available within the community and in the organization. The thing with this program is that they are able to meet the patients at their home or at any location that is convenient for them. So that's another approach taken by this team. A lot of the times patients don't have the means to come to the clinic, they don't have the gas money, so being able to meet at the location of their choice is how this team is approaching the patients. And of course, dental care. Our dental care has been providing oral health education and training to foster good oral hygiene, providing adult emergency dental care, which is the primary efficient tool that we've been utilizing in the coordination of care between medical and dental care. They also offer regular appointments for routine and preventive dental care, which include the usual x-rays, extractions, fillings, and all that fun stuff that you guys are aware of. So the good thing, currently at the Monroe site, we share a location. So there's been times where we have a chronic care patient that comes in and is complaining about a toothache, and for some reason is at the medical department. We've been able to coordinate with the dental clinic, and those patients have been able to be seen within that same day. So even though they were in the wrong department, we were able to provide the dental services because of the communication between the two departments. And the other part of the patient-centered medical home is our behavioral health team. Basically, they are providing support for the patients that have been diagnosed with behavioral health conditions. They provide counseling services. They provide psychiatric medication management when appropriate. And the service for patients that are, they offer service for the patients that are suffering from chemical dependency. And this is a common thing that we see in the patient population with homeless or low income. A lot of the times it's not just a chronic condition, but it's the social factors that are affecting their control of the condition. So I would like to review a little bit of two different cases that I've experienced with providing care and the obstacles that these services have, or the obstacles that the patients might be having with obtaining these services. Based on my personal experience from working at this community health center, I have found it very difficult at certain times to approach the specific chronic care or patient-centered medical home model. Adapting this model can be challenging at times due to the possible barriers that might be present in the patient's life. Many factors can be considered to be the patient's social economical status. Currently, 70% of the patients that we serve at CMAR are at 100% or below the poverty level, making it even harder for them to obtain the appropriate care that is needed. This can be represented in not being able to afford their medication or not wanting to miss work for their actual doctor's appointment. We will discuss a little bit about a patient's case, but because he was the only family member who was working, he felt like missing work was his priority rather than taking care of his health. He felt that the income that was lost with that day of work was not going to be worth that appointment that he had scheduled with that doctor. So I'll go ahead and start the cases. The names have been changed. This is to protect the patient's identity. So David is a 46-year-old male patient with uncontrolled diabetes. Due to the elevated sugars, he is now experiencing complications with his diabetes. He currently has no sensitivity in his feet. He struggles with changes in his vision and has lost almost all his teeth. For several years, David came to the doctor's office frustrated about not being able to meet his goals. The provider would review his sugar levels, which were constantly elevated, and proceed by making adjustments to medication. He would then instruct David that he must eat less sweets and exercise more. All of this in a 15-minute appointment. David was good to go. He was to work on this journey, and hopefully in around 1 to 2 months, he would come back and his sugar levels would have been improved. David left his appointment with more prescriptions, which he was unsure if he would be able to purchase, and many unanswered questions. Once the chronic care model was adapted, David met with the care coordinator for the first time. He expressed that he was frustrated with not being able to manage his diabetes. He expressed that he felt discouraged coming to the doctor's office since he was always receiving bad news. He also reported that he had several questions pertaining to his care, but since he knew the provider had a limited amount of time to meet with him, he did not bring these up in previous appointments. The care coordinator discussed with David the recently improved care model, the services available to him, and the care plan was developed. The initial barriers identified for David were that he was unable to make healthy choices when it came to eating, since he was missing most of his teeth, making this extremely hard for him to chew any type of solid food, explaining one of the reasons why his sugar levels were elevated. He reported to us that he was eating yogurts and puddings, which are really high in sugar. David at this point was connected with our dietary and dental services. Due to the fact that David had to work 5 days a week and could not miss any more work since he is the sole provider for his family, and any time he misses work, this would cause financial hardship. The only alternative was to schedule a weekend appointment. Fortunately, with the implementation of the patient-centered medical home and the chronic care model, extended hours were something that was now available through our clinic, making it possible for David to come in on a Saturday to meet with his providers. He had his dental appointment on a Saturday as well. He also had the opportunity to meet with the dietitian that same day, who discussed with the patient soft and yet healthy foods to eat while in the process of getting his dental care, making this a more efficient visit. Due to David's elevated sugar levels, unlike usual diabetes, follow-up appointments, which are recommended every 3 months, the doctor had requested for him to follow up on a monthly basis, making this extremely hard due to the financial aspect. As a team, we came up with a plan to communicate with patient via phone call on a weekly basis to review sugar levels and to make any possible adjustments in treatment. After the approach taken by our dental department, patient was then referred in order to obtain dentures. By the following office visit, which was around 2 to 3 months, the patient was happy to show us his new dentures. Literally, he was smiling during the whole office visit and mentioned how effective his new dentures was. We were able to confirm this by testing his sugar levels, which have shown a significant improvement. When asking David if there had been any changes in lifestyle, he mentioned that thanks to his new teeth, he was now able to eat vegetables with every meal. We encourage patients like David to utilize the ancillary services as much as possible to ensure the better outcome of health. We can attribute David's success with managing his chronic condition primarily by the services offered by our dental department. A new smile is what made the difference in this patient's overall health. Even though the ancillary services were available to the patient, making a plan that worked with his needs was a crucial component of this case. The second case is Michelle. She is a 19-year-old female patient that has been seen at our clinic since she was 14. When Michelle initiated her care, it was mainly for wellness exams. But after about 2 years, we started identifying that there was something suspicious going on. Her behavior had changed, and the visits were mainly for acute concerns. During these visits, like I mentioned, we noticed that the patient was acting somewhat different. Her behavior had changed. She seemed nervous and anxious most of the time. At this point, the primary care decided to take the team approach. Care coordination was connected with the patient, and at this point, a referral for behavioral health was placed. Michelle then got connected with our behavioral health services. which the care coordinator assisted in scheduling the appointment. Once the appointment time came, Michelle failed to show up to her appointment. The care coordinator reached out to Michelle several times. After many attempts, we were able to finally get a hold of her. Michelle was in tears, mentioning that she was going through a really tough time and needed support, but didn't know where to start. She mentioned that the reason she was unable to attend to her appointment with the counselor was due to a lack of transportation. At this point, the care coordinator arranged medical transportation services in order for the patient to be seen by our behavioral health department and our medical care. Once Michelle met with our counseling services, we were able to discuss the main barriers to care. Michelle had reported that she developed an addiction to heroin, and due to this, she felt like her life was going on a down spiral. She had lost the support of her family and was now homeless. After the discovery of these two main factors, the care team promptly discussed the best possible method to assist with the patient. The initial approach was to get the patient connected with our care management team, and this is to happen at the location of choice of the patient. Like I mentioned, the care management team is able to meet at any location where the patient feels comfortable discussing their care. The purpose of having the care management team meet with Michelle was to obtain further assistance with the chemical dependency treatment plan and also to connect her with any housing support that might be available. We have just initiated providing the overall team support to Michelle. And so far, the motivation of the patient and the efforts of the team show a positive impact. Michelle is ready to get her life back on track. And with the additional support, she has been able to move forward with her care. At this point, Michelle has had the opportunity to meet with her primary care on an ongoing basis. She has also had the opportunity to meet with our dental department. Thanks to the ability of the urgent care appointments, she was able to establish care with the dental department the same day that she met with her PCP, making her time at the community health center as efficient as possible. Due to the neglect in her dental care, Michelle has prolonged treatment, but with the coordination of the services between dental and medical care, she will be receiving more than one service at a time, making it possible for her to focus on the overall treatment of her intensive outpatient care. So the coordination of the teams is what has helped our patients in succeeding with the management of their chronic condition. A lot of the times we try to provide these services, and due to the patient's barriers, we are not able to, but we've been working and finding alternatives to approach these matters. One of the things that we're currently working on is for those patients that don't have the opportunity to meet with our health educator who is in staff or a registered dietitian, or even the provider, we're implementing a call system where we're calling the patients on a weekly or bi-monthly basis to ensure that when they come and meet with us during their next office visit, their chronic illness is not out of control. And this is done by reporting back with the patient and the provider of how their current sugar levels might be doing, their blood pressure numbers. Based on this, the provider is able to make any changes to the medication, and we can deliver this via phone to the patients. So working with this team has made a significant impact in the care of our patients. Regardless of when the patients are diagnosed, whether the etiology is known or whether the symptoms are physical or psychological, essentially all chronic conditions present a common set of challenges to patients and their families. Dealing with symptoms, disabilities, emotional impacts, complex medication regimens, difficult lifestyle adjustments, and obtaining help. Many patients with chronic conditions struggle with the physical, psychological, and social demands of their illness, and support from their medical team is crucial. I like to compare managing a chronic condition with going to college. I feel that's something you guys can relate to, right? We can use this example example, we can use an example of a 20-year-old single man living with his parents who has no responsibilities, whose main objective is to obtain good grades, but only manages to get passing grades. On the other hand, we have a single mom who has a full-time job and somehow manages to get straight A's. Is this luck? I don't think so. If it's not luck, then what is it? The single mom, despite her obligations and the responsibilities that she has, that can be considered as barriers, somehow finds a way to make it all work, thanks to the self-motivation and improving herself and the outcome of her family. This of course, has to be possible with the support of additional services that might be in place. If patients with chronic conditions can obtain good grades, then the role of healthcare is to ensure successful students, effective study methods, and strategies that safely get those students their 4.0 GPA, and support services such as advising to monitor and prevent lowering those grades. Medical care then must ensure that these patients with the chronic illnesses have the confidence and skills to manage their conditions. The most appropriate treatment approaches to ensure optimal disease control and prevention of complications, a mutually understood care plan, and a careful follow-up plan. Well-designed interactions between care team and patients will be needed to complete the important clinical and behavioral work of modern clinic illness care. So like I was mentioning, we have these two different types of students. One is taking the approach of getting good grades and one isn't. Sometimes this can happen in healthcare. What some barriers that a patient might have might not be the same barriers the other one has. But we have to be realistic and find ways that with those barriers we can work around these. These barriers aren't always going to go away, but finding resources and assistance for these is what can contribute to a successful patient outcome. The chronic care model is an evidence-based guideline, a synthesis of system changes to be used to guide quality improvement. Thanks to this approach, we have seen a significant impact in the chronic care patient population that we serve. As an example, the number of the uncontrolled diabetic patients for our clinic has reduced 15% since adapting this model, which was done 2 years ago. The experience using the team approach model has helped us refine and improve the care provided to these patients' illness, and more importantly, to develop a better understanding of what it takes to close the quality gap between patients and the healthcare needs for people with chronic conditions. Thank you.
So Bea asked me to come today because she wasn't able to be here, and because the office has just set up a great agreement with CMAR Monroe. So CMAR is this huge community health center all over the state, and one of the places that they're in is Monroe, sort of northeast of here, and Caroline is. And we are actually going to start having rotations at that site starting at the end of June. So one of the first service learning rotations for the senior class, one of them is going to be going to Monroe. The dentist in charge of there is Luis Acevedo, who graduated from here a couple years ago. A great student, has been working over there, and that's a relatively new clinic. I think they don't think they're just a year or so old, but he's going to be the preceptor for that. And we're going to have regular senior students rotating there doing dental care. And then we're also going to have, that's the SLR program, and we're also going to have a student going over there for the RUOP each summer. And so we have a rising second-year student, what's currently a first-year student, will be over there working in the clinics, doing dental assisting and maybe giving shots. If they're successfully finished their local anesthesia class. I don't know if is there a student that's going there here today? I don't know. But anyway, we're really excited to be working with them. Social work is a huge, when students are doing these rotations, they're working with a lot of different groups for their interprofessional experiences. And social work has been one that I would say in general in dentistry, we sort of think, well, why do you even need that? Even when we did the interprofessional, the IPE third-year program, social work was one of the themes. If y'all remember, the third years or fourth years remember the lady that had diabetes, and I think she ended up dying, the one that was in the hospital. It's kind of a sad IPE case. But the students were kind of felt like, why are we even doing this? You know, and faculty, you know, too. That people were not so. We're trying to think how social work would fit. But I guess if you guys have been in an emergency clinic, you know, we see a patient with an emergency and they they have an infection, so we write them a prescription for antibiotics. And then we kind of just hope they take it, and then we hope that it all works out. That's sort of our approach in dentistry, is hope and then never be around, so we don't have to worry about it because we'll probably never see them again. In the medical model, you know, it was that way for a long time. There's changing, and now social work is moving into our area too, to say, okay, how do we make sure this patient gets their antibiotics? How do we make sure they follow up with you guys and get, you know, you start their root canal and follow up and make sure that they finish it. It's actually a lot in dentistry, I think, so I was really excited that B asked me to come, and I appreciate Caroline doing this. She sits right next to Luis, so they work all the time and have
Close enough.
cases like that. You were going to say something about the fears?
Yeah, so we actually had a recent case, well, two, but one of them, the patient was just there for her consult. It was her initial evaluation, and I was called to the dental department. So here I go, I'm wondering what's going on, and it's this patient sitting on the table having a panic attack. So she had experienced some type of assault in the past, and the fact that all this equipment was close to her face kind of triggered those emotions, and she was having a panic attack at the moment of her consult with Louise, actually.
Yeah, he's mean too, so it's kind of scary a
He's
little
a
bit.
good guy, yeah. So we were able to help the patient. We had her take a few moments. We did a little bit of motivational interviewing and a bit of counseling to kind of go over what was causing her anxiety and her panic attack. She then moved forward with following up with our behavioral health clinic for ongoing sessions with the counselor. So that appointment had to be canceled because of this approach, but now that she's receiving her care through behavioral health and the constant counseling session, she's been able to come back to her dental appointment and be treated. It was an extraction that they were trying to do with her. So she's got that taken care of, but initially we had to take an alternative approach to be able to provide this dental care for her. The other interesting approach I had with the dental patient, she was actually intoxicated, and she was demanding for all her teeth to be extracted at that time of visit. So in that case, we actually had to call the police department to get some assistance because she was persistent about not leaving the exam room until all her teeth were pulled completely. And again, this is another patient that suffers from behavioral health conditions. She was diagnosed with bipolar and schizophrenia as well. So getting her connected to those behavioral health services were a key component in her case. She also sees our medical provider, and the last time I saw her, which was around a month ago, she seems to be stable. So that's how we kind of connect with the services between medical, dental, and behavioral health. And then it's not just always having the dental department referring patients to our services. Sometimes even from behavioral health, we get those referrals. This patient should be followed through the dental department because they're losing weight, they seem to be dehydrated. We just have that correlation between all the teams to ensure that the patient is being referred to the specific team. So, for example, that patient that needed dental care, he was seen at the behavioral health clinic for an initial assessment to start counseling sessions, and when the counseling session started, the counselor noticed that the patient was doing something quite unique. So she asked the patient what she was doing, and she said, oh yeah, I'm trying to dig through here and see if I can find my, is it a partial denture or a partial? I don't know. So she was digging through her purse to find this partial piece of her teeth that were needed in order for her to eat. But when reaching to her purse, she saw that her pet was there. So she was keeping her dental care along with her, where she kept her small dog. So this was a referral that was sent to dental to ensure that patient had the proper education about how to have this proper dental hygiene. So, just a correlation between the teams, it's a very good approach, and we have to understand that these approaches taken are to improve the overall patient's health. It's not just about one thing, it's about treating the patient as a whole. We can't leave one thing untreated to treat the other. We have to consider everything that might be interfering with the patient's overall health.
Have y'all seen the patients that might benefit from this in the emergency clinic or in your rotations on health and homelessness? Rotations?
Any questions?
Thank you very much.
Well, again, thanks for having me here. And thank you.